Well, good morning, everyone, and welcome to this session of Shape Your Future, part of the STELR program here at the Academy of Technology and Engineering. As we gather for this meeting from different places around Australia, I'd like to acknowledge the traditional custodians of the lands from which we meet. I'm joining you today from Ngunnawal and Ngambri land. I pay respect to elders past and present and any Aboriginal and Torres Strait Islander people who join us online today. As we share and discuss our own knowledge and practices, we acknowledge the deep knowledge forever embedded in custodianship of country. Now, today we have a fantastic session from two scientists looking at different parts of your eyes and vision. So we are going to hear all about what's going to be the future of vision and how to prevent bad vision in the future. We'll start today with Associate Professor Lauren Ayton, who's going to talk about her work with your eyes. Thank you, Lauren.
Great, thank you so much. And it's an absolute pleasure to be with you today. I'm just going to share my screen. Fantastic. It's great to be chatting to you all today, and I'm hoping to have some great questions and discussion at the end. As mentioned, both Jennifer and I today are going to talk to you about our area of research, which is in ophthalmology and optometry research, and the wonderful title of Can You See What I See? So to start with, I thought I'd give you a little bit of a crash course in the eye and how vision works, so that then we can understand what the research that Jennifer and I do is about. And so this schematic here is really showing how vision works. So what happens is that light from objects in the environment around us comes into our eye and is focused on a part of the eye called the retina, which is right at the back. And what, sorry, bear with me a second. Excellent. So what you'll see here is that the back of the eye where the light is focused, if your central vision, it's called the fovea, which is the very center part of the retina. And then the messages from there are sent back via some nerves along the optic nerve to the brain, and that's when we can see. So within the eye itself, it's not going to work, sorry everyone. There we go. So there's a whole lot of different parts of the eye that make up your visual system. And one of the problems with the eye and with vision is that there's lots of places where things can go wrong. So this is a cross section of the eye. So if you think about where the cornea is at the front is literally at the front of your face. And then this is cutting through your head and what you would see within your eyeball. So when the light comes into the eye, it comes through the black circle at the front of your eye, which is actually a hole. The light goes through there, it's focused through the lens and then focused onto the retina at the back of the eye. Now, the retina itself is the tissue that I'm particularly interested in. And this is a really interesting part of the body. So it's about the thickness of a piece of tissue. And it's about as fragile. So you can imagine that doing surgery or any sort of interventions on this tissue is really challenging. The really interesting thing with the retina is it's almost back to front to what you would expect. So the light comes from the front and actually goes past the retinal ganglion cells and the bipolar cells, which are the communicating cells in the retina. And it has to go all the way to the back of the retina to these cells called rods and cones. And they are the cells that are actually responsive to light. So once those cells react to the light, the message is then passed back through the bipolar cells and the retinal ganglion cells and then go back to your brain. So it's a very interesting backwards kind of setup. Now, as I mentioned before, there's lots of things that unfortunately can go wrong in that process. And I'm going to show you some pictures now of the back of the eye. So I mentioned before that there is a nerve that takes the messages from your brain, from your eye back to your brain. And this is what the nerve looks like in the back of the eye. So this is the optic nerve, and this is all of the blood vessels that take blood to and from the eye. This little dark spot here is called the macula, and that's where your central vision comes. So when you're reading or looking at faces. And this is what a healthy retina looks like. But unfortunately, you can get a whole lot of different diseases which can change the appearance of that. So this is a condition called age-related macular degeneration, and this causes damage to the retina and in some cases bleeding, as you can see in this picture. Glaucoma is a disease which Jennifer will talk about in some detail, and this is where the nerve that takes the messages from your eye back to your brain gets damaged. And you can see that the appearance of this nerve is quite different to the healthy looking one. And again, Jennifer will probably talk to you a bit more about that. And then one of the conditions that I work in more detail is called retinitis pigmentosa. And you can see where it gets its name from. So the pigmentosa refers to the fact that you have all of these different pigmentation around the outside of the retina. And this is an inherited form of eye disease, which is actually one of the most common causes of blindness in working age people. And so these are really the diseases that Jennifer and I focus on, and you'll hear a bit more about today. So as I mentioned just then, my research is in what's called inherited retinal diseases. And so they're the most common cause of blindness in working age people. They're genetic, and so they are passed down in families, but there's a lot of different genes responsible. So we now know of over 300 different genes, and they can be quite variable in how they present. So it's not as simple as if you have the gene, you're going to have a particular progression of vision loss. And so this has been really interesting research because we have to try and learn more about what the genes mean. Generally, these conditions are diagnosed in teenagers, older children and teenagers, so probably about the age of you guys actually. And people do tend to lose significant loss by the time they're around about 40. So this is an image of what it looks like at the back of the eye with someone that has one of these inherited retinal diseases. And what you can see is that most of the pigment and those black splotches are out towards the edge of the retina. And what that is showing us is that in these diseases, the outside retina is damaged first, and that means you lose your outside vision first. And that's called peripheral vision loss. So this means that people can develop what's known as tunnel vision, where they can only really see directly in front of them. And that can be really hard for things like walking around and avoiding obstacles, or obviously driving. So my research is got a few different areas. So we're learning more about these particular diseases and what they mean to people who have the conditions. But also we're trying to come up with new treatments that can help people that have inherited retinal diseases. And so one of the main areas of my research is in what's known as bionic eye, also known as a vision prosthesis. And everyone, when you hear about bionic eyes, immediately thinks about, you know, robots and $6 million man and all sorts of tech things. And it is quite amazing technology, but it's not able to give people X-ray vision or, you know, amazing perfect sight, unfortunately. So the idea with these is that they're electronic implants that get implanted either into the eye or into the brain. And it allows people to restore some of their vision when they've lost it from these diseases. So up in the top, you can see a picture of what the electrode array looks like. And it's next to a coin from the US. And so you can see that the electrode array is very small. And so what happens is it's implanted into the back of the eye. And then we can get people to wear a camera, which is shown in that large image on the slide, which takes a picture of what the person's looking at, and then it translates that to electrical signals, which can be sent to the electrodes within the eye. So the idea is that we're basically trying to replace the cells that are damaged in the eye with an electrode, which does the same kind of job. The other area of research that I'm working in is, again, trying to restore vision to people who have lost their sight. And this is one called gene therapy. And so this is a really complicated picture, so you don't have to worry too much about all the details. But the idea with gene therapy is that people that have these inherited retinal diseases, it's happening because one of the genes in their cells isn't working properly. And so what we need to do is replace that faulty gene And we do that by putting it inside a tiny little virus that we can then inject inside the eye. So basically, this is taking out the faulty part of the cell and replacing it with one that works. And so then the people don't go on and lose their vision. So it's quite an exciting area as well. And this is just a picture of how we do that. So I mentioned that we have to inject this treatment into the eye. And so the injection goes from the front of the eye through the white part there. And you can see it inject in underneath the retinal tissue at the back of the eye. And you might remember at the start, I was mentioning that the retina is very fragile. So it's like a piece of tissue. And so it's very delicate surgery. And we have really talented surgeons that are able to give these treatments. So that's sort of the overall gist of my research, but I really wanted to spend a bit of time as well talking about how I got to where I am and what I've done in the past. So when I finished high school, I actually decided I wanted to be an optometrist. And the reason for that is both of my brothers have vision problems. One of my brothers was completely blind and the other one needed glasses. And so I sort of wanted to know why you could help some people who had vision loss and not others. So I decided to enroll in a Bachelor of Optometry. And so I did that for a few years and then worked for a little bit as an optometrist, but then decided that, really what I wanted to do was research. So I did a PhD, which is an advanced degree, which allows you to go further into research. And I did that looking at kids and looking at educational performance, so how children go at school and relating that to their eyes. I then did some work looking at people that have had a brain injury and what happens to their eyes and their vision. And that got me really interested in people that have low vision and blindness as well. So I became involved in the field of research that I'm in now in about 2010, so about 12 years ago. And I've worked on the bionic eye, both here in Australia, but also in America. I lived in America for a few years, working on their bionic eye over there. And now I'm back in Australia and continuing on with this research. So I thought I'd show you a couple of slides and of, where research careers can take you, I guess. So this is some photos from my time in America. And behind us in this photo is a clean room. So this is a room for manufacturing bionic eye devices. So it's where the electrodes are built and all of the wires and bits and pieces. And one of the really interesting things for me, coming from a clinical background, when I moved to the US, I found out that I was going to be helping to set up this clean room. And so I'd never done anything like this before, but it was an amazing opportunity. So I got to work with the engineers that are in this picture here. And we basically worked together to set up this clean room so that the devices could be made. And then my job from there was helping them to run trials to see how effective those devices would be to help people get back their vision. And one of the other really cool things about living in the US is that we were right up the top of the US. So we were almost living in Canada. And so it was an amazing place in terms of the weather. So this is a photo of my son. We used to get about, 4 foot of snow overnight, which is, probably about almost the height of some of you or a little bit over your heads perhaps. And it was a really great experience to be able to live over there for a while. So the other thing that I've been able to get really involved in research is trying to come up with ways to take the research that researchers at the university develop and then putting it out into businesses and making it available for people that can benefit from those treatments. And so this is a couple of pictures here from a group called Spark, which is basically about trying to let people in the broader community know about what's happening at the university and also trying to get companies to invest in some of these treatments. So it's really exciting to be part of research because you're coming up with new treatments and new knowledge about eye diseases in our case, but it's really important that that gets through to people that need it. So that's a really cool thing I've been able to get involved with as part of my PhD. So one of the things we were asked to talk about today are some thoughts for my high school self and what I would tell myself if I could go back in time. And these are probably some cliched quotes that you guys will have heard of before, but these are really, really key to how I feel about my job. And the first one is, if you do what you love, you'll never work a day in your life. And this is so true. I'm really privileged. I love the research that I'm doing. I get to work with people that are really interesting and really motivated to try and stop blindness. And so that sort of keeps me wanting to come into work all the time. The other thing that's really interesting about research is you get to do really diverse things. So, I get to travel overseas to go to conferences. I work with people in different universities around the world. And so I'm always learning new things, which is really a great thing for me and for a lot of people. The next, quote that I'd like to leave you with is, there are no wrong turns, only unexpected paths. And this is always really important to remember. I think quite often, especially as you're going through high school and starting to think about what you'd like to do after high school, you can feel a lot of pressure that you have to make the right decision. But, what I've found throughout my career is that, no matter which path you take, there'll be something interesting down the line. So, I think it's about taking some pressure off yourself when you're in high school. You can make a decision now and then change your mind. That's what I did. I thought I would be a full-time clinician, and I've ended up more in the research space and loving it. And one of the last ones I wanted to leave you with too is that, I guess remembering you're obviously very high achieving students in science. And I think it can become really easy to get really involved in what you're doing and sort of forget about having a little bit of balance as well. So, I know that you guys are young and haven't got quite as many commitments as you will later in your life, but work-life balance is really important. So thank you so much for the chance to talk to you guys today, and I'm very excited to hear what questions you might have about the research or about doing a research career. I just wanted to end by talking about the fact that one of the other things I love about research is that it's very collaborative. So this is my research team. So we have surgeons, we have doctors, we have people that work in the lab, we have people that see the patients in the clinical trials side of things. And it's a really great environment to be able to talk amongst each other and learn from each other. So if you're interested in going this path, I think you'll find that you really can learn from others the whole way through. So thank you so much for listening, and I think we're going to open to questions.
Thank you, Lauren. We might take a few questions, but I guess I'm really excited about listening that, as you say, the path that you have from optometry to now actually doing the eye work, which is great. So we might merge the questions because I'm pretty sure I'm going to have some similar ones for both of you at the end for sure. So I will introduce Dr. Jennifer Fan Gaskin, who's going to do the second part of our presentation today. And as Lauren's mentioned, she works on glaucoma. So I'm keen to hear where my eyes might do in the future. So thank you, Jennifer.
Thank you for the introduction. And I'm also going to share my slides now. Great. So it is a great pleasure to be here today. As Lauren had said, it's really exciting for me. One of the passions, as well as the work I do during the day, is actually to try and excite and inspire the next generation to a career in science, and in particular in medical research. So I hope I can do that today and share some of the things that excites me about my work. So I am an ophthalmologist, so that means that I did a degree, my undergraduate degree was in medicine, And then I went on to do specialized training in eye surgery or ophthalmology. So I'm a consultant, I work as a consultant ophthalmologist at the Royal Victorian Eye and Ear Hospital in Melbourne. And I'm also a principal investigator at the Centre for Eye Research Australia, where Lauren also does some research, and I focus on glaucoma and ocular fibrosis research. So they're the two kind of different aspects of my work. I'm just going to advance my slides. So as Lauren had very kindly touched on, the area that I work in, the condition that I'm particularly interested in is called glaucoma. Now, glaucoma is actually the commonest cause of irreversible blindness anywhere in the world and here in Australia. So that means it's the condition that most likely to blind you permanently. I don't know if you know much about glaucoma, but if you ask around, I can be sure that you will have someone in your family, usually someone elderly, so like a grandparent, who suffers from this condition. And people suffer from it to different extents. So fortunately, not everybody who gets the condition become blind, but many can do if the disease is not well looked after. And in Australia alone, it is estimated that about 300,000 people suffer from this condition. So if you imagine 3 full MCGs of people, full of people, that's how many people we have in Australia with this blinding condition. And it is actually estimated that by 2040, this number will double. So we're going to have 6 MCGs full of people with a potentially blinding condition. So that's obviously very concerning. And so what is glaucoma? Lauren had mentioned that it is a disease of the optic nerve. So it's a condition where the nerve fibers that connect the eyeball to the brain are damaged. So if you imagine that the cable is damaged, we're not going to get smooth or successful transmission of the information that enters our eye to the brain to allow us to see. So therefore we lose vision. And in the past, glaucoma used to be thought of as resulting in tunnel vision, because it starts off by affecting the nerves that influence our peripheral vision first. We lose our peripheral vision, and we are only left with the very center of our vision when the disease is very advanced. So people think, oh, well, that's what you get tunnel vision, a bit like how Lauren described retinitis pigmentosa. And so if a patient gets told that they have glaucoma and they cover up one eye and they have a look and they think, well, I can still see everything, I don't have tunnel vision, therefore I must not have glaucoma. But more and more we're realizing that that is actually incorrect. And these days we've got very clever researchers who've looked into simulating what life is like, or what sight is like for someone with glaucoma. And this is actually more like what a glaucoma person sees. So here is a typical underground scene in London in the subway system. And if you follow the red dot at the back of this man's head, you'll get an idea of potentially what a glaucoma person sees. So hopefully my video will work. So follow the red dot around. So this is someone with glaucoma looking around the scene. And so I don't know if you notice anything unusual other than this red dot moving around. So just let it play for a little bit longer. And then if we move on to the next slide, this is actually so now it's explained. So this slide is showing you a patient with glaucoma, someone with glaucoma. If they're looking at the red dot, this patch of shadow here is actually their blind spot. So they've lost some sight there. And this is what they actually see when they're scanning around the room. So now that patch of loss of sight, that blind spot's being highlighted by this blue dot, this blue line. So again, if you follow the red dot around the room, you will see that the blue line actually highlights patches of missing vision in this patient's sight. So that is actually what a glaucoma patient sees. They don't see tunnel vision or a black patch. It's actually just like a photograph that's had that background airbrushed in. So the gap's just been filled in with sort of background information rather than a black patch. And that's why it is so difficult for patients themselves to detect that they have glaucoma. And you can see why that patients, if they were not picked up early, often present by the time they've got hardly any vision left, because slowly their bits of missing vision just gets filled in by the background information, and they can't themselves actually perceive that they have any problems until they start bumping into things or seeing things on the road or hitting things when they're driving. And that's a real concern and a real problem and danger for not only themselves, but people around them. So when we're treating glaucoma, not only do we want to preserve their vision, but we want to preserve the patient's quality of life. And poorly controlled glaucoma can lead to total blindness. And treatment involves lowering the eye pressure to protect the optic nerve. And we can do this by either with eye drops, with laser therapy, or with surgery. And so the research that I'm involved in is looking at improving our glaucoma surgery options. So currently, the most common operation performed for glaucoma is called glaucoma filtration surgery, where we create a drain from the inside of the eye that allows fluid to drain to the outside of the eyeball by creating a little blister of fluid that allows, that collects the drainage. So it's a surgically created canal, and it increases the fluid flow out of the eye and therefore reducing the eye pressure. And this is kind of what it looks like in a real patient. So you can see this little flap, it's like a one-way valve, allowing fluid to drain out of the eye. There's some sutures holding the valve in place, and fluid is drained into this area here. However, if we just do the surgery like that, the risk of it failing by 5 years is 50%. So half of these operations will fail by 50%. And that's clearly not good, because we want this operation to work for as long as possible. And the reason that they fail is because naturally our body wants to heal. So the drain that we've created scars up and stops working. So currently what we do is we apply a very strong anti-cancer medication to the surgical site, to the place where we do the operation, to stop the operation from scarring up. It works well in stopping scarring, but it can actually cause some long-term problems, such as making the tissue, the area very thin, and therefore the tissue or the wound breaks down, causing leakage. And if the wound leaks, that means bugs can potentially get into the wound and into the eye itself, causing very severe infections. And these are some of what some eyes with this infection can look like. So you can see that the eye is extremely red, and the area of stark whiteness is where the strong anti-cancer drug, the mitomycin, has been applied. So all the blood vessels have died in that area, and the tissues become very thin, and it probably is leaking a little bit, and bacteria has got into the eye through that way. And you can see even down the bottom here, this eye has even got some pus in the eye from such a severe infection. And eyes that develop this infection do badly. They often do not, they lose their sight, they often don't recover, and sometimes they even lose the eye altogether. So my work is trying to improve on the current method of anti-scarring. And the drug that I'm currently working on is called 3,4-dihydroxyflavanil, which is a very commonly found antioxidant. It's found in coloured vegetables, fruit, and green tea, and it's the most abundant antioxidant in our diet. So we actually can get quite a lot of it just through eating healthy fruit and vegetables. And this drug has been found to be protective in other diseases such as heart disease and even some cancers. So we're working on this drug, looking at how it reduces scarring in glaucoma filtration surgery. And you can see here is a control, and here is the drug itself, and here's mitomycin, which is what we normally use. And red is sort of the scar tissue, and we want to see less red than normal. So if we just use a control, there's heaps of red really densely packed together. And even with mitomycin, there's less red, but probably compared to the other two, dihydroxy gives you the least amount of scar tissue and not very densely packed together. So here the graph shows it in numerical terms. So it's showing really promising results in terms of anti-scarring. And furthermore, what we think may be an additional benefit with dihydroxyflavanol is that it's also got an antioxidative benefit. So it reduces stress in the tissue in other ways, therefore stopping scarring in other ways than just stopping the accumulation of the scar tissue. So we think that it may be a safer and better drug and better anti-scarring medicine than mitomycin C. So who will benefit if this drug comes to come into use? At the moment, about 100 glaucoma filtration operations are performed per million people per year in the world. And in Victoria alone, we estimate about 800 to 900 of these operations are performed every year. That mitomycin C, the anti-cancer drug, is also used in other glaucoma surgeries. So if we have a better medication that comes along, it will not only help with those patients who have glaucoma filtration surgery, but also other operations, so more patients could potentially benefit. So that's a little summary of my current research, and I thought I'd also include a little bit about my career journey, like Lauren has, so that you know how I've got to where I am today. So as I mentioned, I did a medical degree, so Bachelor of Medicine and Bachelor of Science, Bachelor of Surgery at the University of Auckland, which is where I grew up and where I'm from. And then I worked as a junior doctor in the hospital for the next 2 to 3 years. And that's what most people who graduate from medicine have to do. We do 1 or 2 years in the big hospitals, rotating around different specialties. And then I decided that so during my last few years of medicine, during our different clinical attachments, I realized that I loved eyes and I loved ophthalmology, and I wanted to spend my life preventing people from going blind. So then I decided to embark on a doctorate degree. So it's a doctorate of medicine by research thesis. And then I did that at the University of Auckland as well, researching on a different part of the eye from what I'm working on now, researching on the cornea, which is the clear shield in the front of your eyes. And I did that for a couple of years. And then I got onto the ophthalmology training program, which is an Australasian-based training program that qualifies me to become an ophthalmologist at the end. So I did that mainly in Auckland. And then I realized that the part of the condition that interested me the most was actually glaucoma, and I wanted to be a glaucoma specialist. So then I came to Melbourne at the Royal Victorian Eye and Ear Hospital to do my glaucoma fellowship. And this was my supervisor and mentor at the time, Professor Jonathan Krausner, who's a world-renowned glaucoma specialist and researcher. And then I was recruited to stay on at the Eye and Ear Hospital to become a glaucoma consultant ophthalmologist. And I also continued doing research at the Centre for Eye Research Australia, where I initially started as a research fellow and to now becoming a principal investigator and lead my own team. So these are 2 of the women I work with in my team. We all work on anti-scarring research in the eye. And as Lauren said, you know, one of the best things about our jobs is that there's a big diverse range of the things that we do. And in my job, I really enjoy having the variation. So not one day is the same as the day before. So one day I might be doing surgery, operating on people's eyes, or I'll be in clinic seeing patients, or teaching, you know, junior doctors or registrars training to be ophthalmologists on what we're doing on parts of ophthalmology or glaucoma. And then one day I might be in the lab looking at cells under the microscope and testing this drug that we're working on. Or I might be at a conference giving a talk about my research or about an aspect of my clinical work. So, you know, they're just some of the examples of what my work involves. And you know, and people often ask me, what's the part that you like the most? And I can't honestly say there's one part. I love the patient interactions, getting to see different people, talking with them, helping with their, you know, to improve their sight or prevent them from going blind. That's an extremely rewarding aspect of my job. But, you know, doing research, being in the lab, using a different part of my brain to really think about how can we make things better for patients, maybe not tomorrow, but 10 years from now, is something that, you know, stimulates me in the long term. And then being in theatre is another exciting aspect of my work. So being in the operating room, everything is quiet and controlled and everybody knows what they're doing. And we're all there for one purpose, and that is to perform the operation that's planned for that day. You know, they're all amazing aspects of a working life. So I hope that some of you are interested in heading down a potentially medical or clinical career, but also looking into doing some medical research. And something that I've been involved with recently that's particularly exciting is that I've been named a Superstar of STEM by Science and Technology Australia. And through this role, we are trained and also encouraged to go out and talk to young female students into and exposing them to a career in STEM. And so I've really enjoyed being out in the schools talking to high school students about my job and how I've got to where I am today. So that's my talk in a nutshell, and I'll be very open to any questions, and I'm sure Lauren will join me and we can answer your questions together.
Definitely. That was, yeah, great insight into the actual what work happens in your eye for, you know, millions of times every day, really. Everything you look at is happening there all the time. I guess my top question is, why the eye? Like, you've both been, I mean, Lauren, you said you'd be ophthalmologist from the start, but what drew you to that particular kind of organ and part of our anatomy? Maybe Jennifer, you can go first.
Yeah, I can go first.
So
I mentioned before that I became interested in ophthalmology during my one of my last clinical rotations as a medical student. So as a medical student, you get rotated through, you know, just about all the different areas of medicine. And when I did ophthalmology, I never even considered it before. And I was sitting in a clinic with an ophthalmologist just observing, and she was telling an elderly man that he was never going to see again for the rest of his life because he had macular degeneration, so one of the conditions that Lauren mentioned. So he lost his central vision to where he could not recognize any faces, not read, not see what's in front of him. And he hadn't realized that it was permanent. So when he was told this, the look on his face and his wife's face were just devastating. And at that moment, I realized this would devastate me if I got told this news. So what else am I going to do with my life than try and prevent this or treat these conditions? So I had one of those lightning sort of moments where I realized this is what I wanted to do.
I think, yeah, mine's probably very similar, I guess. And I think I mentioned before, both of my brothers had vision problems. And so, you know, I kind of grew up with, you know, going to see the optometrist and the ophthalmologist regularly as well. But yeah, same thing, you know, I used to always just think, you know, what if it was me? And obviously I can see what it does to my family too. And it is a really exciting area because things are changing so quickly now, you know, so the conditions that actually both Jennifer and I work in, you know, 15, 20 years ago, there were no good treatment options for them. And now we have a lot more that we can offer people. So it's very exciting.
Yeah, it really is. And it's such an important thing that when you lose it, you don't realize how much of your life is dependent on having it working. Yeah. So my kind of next question is there's been something where you, I mean, well, actually, there's one from Jennifer's that I want to ask, that the new antioxidant drug that you're using instead of the older one that's not quite as good. How did you come across that?
So one of the scientists that I worked with, Dr. Elsa Chan, had worked on it in a different part of the body. So she actually thought, well, worked really well in cardiovascular disease. Why don't we see how it works in the eye? And that's the great thing about collaborating with different scientists. You know, sometimes they don't have eye backgrounds. She came from a pharmacology background, so she was already very proficient at testing medicines, and she had worked on this drug. And, you know, this collaboration and thinking outside the box to bring a new drug to the eye is how medicine progresses and develops.
Fantastic. Yeah, I was kind of keen of that. And Lauren, with yours, the thing that really probably gets everybody is the sticking a needle right into the back of your eye. Right? You've definitely got to stick something in there. And I suppose even with yours, Jennifer, it's people saying you've got to operate on a very delicate part of the body. What are those conversations like when you're trying to reassure somebody that, hey, it's still research and everything, but we're this is going to make it better? And have you had people go, no?
Yeah, no, and you're right. Look, it's a really interesting thing, actually, because I think it's a real kind of mental block for a lot of people about the idea of getting a needle in your eye. It's actually quite common now. So we mentioned before macular degeneration, and there's a really effective treatment for macular degeneration, but it does require, having a needle in your eye every few months to sort of stop bleeding from happening at the back. And so often the discussion is around the fact that, it is literally life-changing. If you have these treatments, then you can protect your sight. But we're very aware of it. So there's a lot of research going into other ways of being able to get drugs into the eye. The problem is the eye is really good at keeping things out. So, Jennifer mentioned before about what it's a problem, right? When there's an infection inside the eye, it can be really tricky. And so we have to kind of get around the eye's natural defenses. And so there's been some interesting work looking at using ultrasound to try and help drugs to get through the different surfaces of the eye to get inside. And there's also some work going into making little devices that you could actually implant in the eye. So you still need to have a surgery, but it'd be just a one-off, for example. So rather than having to have lots of needles, you could just have something done once. So there's a lot of research going into getting rid of the needles, but they're pretty important still at the moment.
Yeah, I know that I would definitely be thinking 3 times if I was going to stick something in my eye. It's crazy. Yeah. You both have kind of worked through a system, but now you are helping, obviously, other people coming up behind you in the STEM field. What are some of the exciting things about working with younger people and showing them the ropes a little bit and going, because obviously some of the kids who we're talking to today will be coming on that and they think, oh, we just got to take everyone else's kind of orders until they get to a certain time. So
I think I'll jump in first in this one. Look, I think one of the really cool things for people coming through now is that it used to be quite siloed research. So people that worked in the eye, and people that worked in the heart, worked in the heart. And I think that's really stopping now. And Jennifer's research is a perfect example of this. So I think that's something that I really want to stress to everyone listening, that, you can kind of have this diversity in your career, because people are now realizing that the best research comes when you put people with different backgrounds in together. And so it's really exciting, I think, that, for the guys coming through now, you're going to actually be able to have that from the start of your career. Whereas I think for Jennifer and I, it's really becoming more recently.
Yeah, I totally agree with Lauren. And I want to add to that too, because you might be someone who enjoys, studying the art subject. So you might think, oh, I love English, or I love languages, or I love history, or I love art history. Therefore, I'm not going to go down a career in science because, that's just not for me. And to be honest, I loved all of those subjects too at school. And then I was, coming from an Asian family, I was quite good at school. So my parents and people around me kind of said, oh, well, you should think about doing medicine. And so when I said that to some of my teachers, they said, why do you want to do medicine? You can actually, communicate with people, and you can speak, you can relate to people. Why would you want to go down a career of science? But actually, how much more important is communication to people who are sick, or who might need to have surgery, who might be doing a clinical trial like what Lauren's involved with, than someone who, than being able to communicate it to them. So just because, I don't want people to feel like they have to be pigeonholed into one area, we need nothing more than people with different talents and different strengths to work in medical research and in science and in clinical fields.
Yeah, because really you said it perfectly. You do need to still talk to people and do that and meet people on a level of what that is. And so I guess the other thing that came out in your career journeys was you have actually changed countries within the course of your research careers. And how difficult a decision is that to be when you get offered an opportunity that's actually in a different country to make that decision to go and do that thing for as long as it's going to take?
Yeah, so the timing for mine was a little bit tricky because I had a young baby. So I moved overseas when my son was 1. And so it was a bit tricky in terms of that. It's a very long flight to America with a 1-year-old. But look, it was fantastic. And I think it's a really great opportunity. I'm very lucky that I had it. But it sort of just gives you an experience of how research is done in a different place. And I was actually working for a company. So it was a company that had come from the university. And so they had a different way of doing things too. So look, it's something that it's actually one of the things I love the most about my job is being able to go overseas and work with people over there.
Yeah, I totally agree with Lauren. Yeah, before COVID, we'd probably be going to conferences overseas a few times a year, and meeting other researchers who are doing similar work to you from a different part of the world and talking to them about it, collaborating, bouncing ideas with each other is one of the best things. Maybe over a meal or a glass of wine or at a social function. But that COVID sort of stopped a lot of that, but it is starting back up. Now, in terms of me moving to Melbourne from Auckland, I came originally with the plan was just to come for a year to do my fellowship and then go back to Auckland, where my husband was for that year. But then because of the opportunities here and how much I love living in Melbourne, I had to convince him to move over. And luckily he's got a job that's in relatively high demand, so he could make that move. But yeah, these are sort of important considerations. Although it is, the world is getting smaller, it is easy for people to kind of move around COVID pending and do the work elsewhere.
Yeah, and I think it's a great thing with STEM particularly is that there are people doing different parts of it all over the world, and you can go and see that for a year and the number of times even in these webinars it's come out like, I was only going for 6 months, I was only going for a year, and then the next opportunity came, which it's a lovely thing to see that those, and you taking those chances, exactly like Lauren said, there's no wrong turns, there's just an unexpected path that produces a new result, which is just fabulous. So I guess we'll kind of wrap things up, but I guess if there was one thing that you really kind of love doing, I know Jennifer said I can't pick one, but if there was one thing, even just on the journey, there was one day that was just a really great light bulb day, a really great moment that you went, yep, nailed it today. Do you have something like that you kind of look back and go, yeah, that's my light bulb moment?
So for me, it was actually the day that we first turned on the bionic eye implants. So basically what happens is the bionic eye implant gets put into the eye, and then the people need to just have a couple of weeks for the surgery to calm down and to recover from that. And then we literally have a session where we get them to sit down and we turn it on. And many of you might have seen the videos online about the cochlear implant. So it's the same sort of thing when they first switch it on and someone can hear for the first time. But I'm getting goosebumps thinking about it. The first time that the people sit there and go, oh wow, I can see that. I can see what you're showing me and what you're doing. And that for me, it was so much work led up to that. And that 1 minute where we went, okay, this worked. Yeah, it was amazing.
That sounds incredible. I guess for me, it will be not as groundbreaking, but also, equally impacting for the individual patient. So, I didn't really talk about cataract surgery, but cataract is another very common blinding condition that is fortunately reversible. It's easily treated with an operation. And in places, first world countries like Australia, it's very commonly done and people get it before they've lost very much sight. But I have done a little bit of volunteer work in the Pacific Islands, and I used to go out to the island of Tonga a little bit. And because of the limitation to access to healthcare there, patients there can have very severe cataracts before anything is done. So they rely on, aid teams from overseas to come and do the surgery, or otherwise they have to wait for a very, very long time to have it done by the local doctors. So it's taking the patch off the day after the surgery on someone who really couldn't see to, barely see to navigate, and you take it off and she could see her granddaughter in front of her, and just the look, and when she hugged her and seeing her granddaughter's face clearly for the first time in such a long time is just so moving, and you can just see the profound change it has made on her. And I think what is important from both Lauren and my story is that it's really about the people. Our work is important and valuable and means something to us because we are making a difference for others, and I think that's why we both love our work so much.
Oh, I would love it too if I was doing what you guys are doing. I think it was still a very groundbreaking for that woman, Jennifer, for sure. Definitely. So thank you both for joining us today. You've come from two very fantastic STEM programs. Jennifer's been a superstar of STEM and Lauren is a tall poppy. You guys go out and talk to school students through both of your programs about what you do, and other people as well. So it's been a really great chance to talk with both of you today. The Shape Your Future series is supported by the Victorian Challenge and Enrichment series, and we're very pleased that they're helping us bring these out to school students in their classrooms. So we have a follow-up survey if you'd like to give us some feedback on these sessions, and there are also some worksheets that you can extend your knowledge on Lauren and Jennifer's work that you can access through our website or through emailing us at the STELR program. So thank you all for joining us today, and we will be back with our next Shape Your Future soon.